So I am presenting a case of Vogt Koyanagi Harada syndrome. To start with, it is a rare autoimmune bilateral condition described as uveo-meningoencephalitis, seen in young adults, more commonly in pigmented races. It is characterized by Vogt Koyanagi, who described it as poliosis, vitiligo, alopecia, and anterior uveitis, and Harada, which is characterized by bilateral posterior uveitis with exudative retinal detachment and pleocytosis and CSF. A 53-year-old gentleman presented with bilateral diminution of vision associated with fever and headache. His best characterized visual acuity was 1/60 in the right eye and 6/18 in the left eye. And for near vision, both eyes N18. Ocular examination showed bilateral conjunctival congestion with anterior chamber cells grade of 2 with fine keratic precipitates. On fundus examination, it revealed a bilateral disc edema with bullous exudative retinal detachment, and the fundus fluorescein fundus fluorescein angiography revealed bilateral disc leakage with multiple areas of subretinal pooling over the posterior pole. B scan showed increase in retinocoroidal thickness. And we had sent the patient for ENT examination. So it showed moderate to severe mixed hearing loss with perforated tympanic membrane in bilateral ears. Dermatological examination showed no specific signs. Patient was tested negative for HIV, hepatitis B antigen, ANA and ANCA, and blood culture showed no growth. MRI of the brain showed bilateral ethmoidal and right frontal sinusitis with bilateral mastoritis. Patient was treated with intravenous steroids, intravenous methylprednisolone, 1 gram for 3 days, and we had followed with tapering doses of oral steroids. And after 1 year of when the patient presented, patient had come with a complaint of poliosis of eyelashes. And on further examination, on fundus examination showed sunset glow fundus with well-maintained visual recovery. Weak-Age syndrome involves a T-cell mediated autoimmune deregulation that targets melanocytic self-antigens. It usually affects the melanocytic tissue of the eyes, the CNS, inner ear, and skin of those individuals related to HLA-DRB1. The disease is characterized by a prodromal stage, acute uveitic stage, and convalescent or the chronic stage, and a chronic recurrent stage. Differential diagnoses include those other causes that maybe that cause panuveitis and posterior scleritis with sympathetic ophthalmia, infectious choroiditis, and rarely intraocular lymphoma. Goal of treatment is to reduce the inflammation and prevent the relapse and avoid any complication that can cause poor visual prognosis. To conclude, I may say that Weak-Age syndrome is a rare multi-system autoimmune disorder, mostly affecting the middle-aged patients around the 4th to the 5th decade. It requires early and aggressive corticosteroid management with immunosuppressive agent to prevent ocular complication, leading to poor visual prognosis. Thank you.
Thank you, Dr. Reeja. Have you done an OCT on your patient?
Yes, ma'am. I actually could not retrieve the image for it. It showed multiple areas of extensive subretinal fluid.
Okay. Because the OCT helps you, differentiate the different pachychoroid spectrum diseases. So, and to follow up also, how the fluid is resolving and things like that, the inflammation is subsiding.
And also in these conditions, if the patients are in advanced stages, Reeja, I think IV methylprednisolone is the first line of management. And they start with IV methylprednisolone, move to topical systemic corticosteroids. And today, as immunosuppressants are taking over as a first line of management in these cases, along with the steroid therapy, they've also tried newer drugs like mycophenolate mofetil and rituximab, which is, I think, gaining a lot of first-line preference in such cases because it helps in restoring vision earlier for such cases. So that has been like a change. So initially, we used to start with steroids, taper them down, and then introduce the immunosuppressive. But today, immunosuppressives are coming in as first line of management with the steroids. especially in cases which involve a lot of posterior, uveitis with exudative detachments.
Usually, usually it is exudative detachment and posterior pole involvement. We can immediately start IV steroids. So that's correctly told.
Right.
Sangeeta, you want to add anything?
Dr. Reeja, for how many days the oral steroid was given?
We started with IV methylprednisolone, 1 gram. After that, we had started tapering. We had started with 80 milligram for 1 week, and then we subsequently started tapering the dose.
Okay.
But how long did you continue it?
Yeah, exactly the question.
How long?
We continued for 3 months.
So, Sangeeta, you need to add on.
Sometimes you might need to continue it for 6 months.
6
Sometimes,
months,
like a few of my patients, they are on 5 milligram OD dose, and they're still there for 6 months, because the moment we stop steroids, it comes back. Not sometimes, most of the times, I give around steroids for around 6 months.
6 months.
Very low dose, but I keep on giving.
Yeah, that is the preferred practice, at least 6 months. Yes.
I think some of these chronic patients themselves know when they step down from that 30 to 20, they'll say,
they're gonna come back and tell you. True. And I think, what, this is kind of something that as we retinal surgeons have been practicing, Supriya, that a lot of our uveitis patients also, if we kind of treat them with low dose steroids over a longer period of time, when we put them on immunosuppressants like Imuran and all that, they start doing better, and the number of recurrent attacks are much lesser. So I think there's an apprehension of using steroids, but I mean, you should not have it in such cases where we see a lot of features like granulomatous polyangiitis, the previous presentation. All these patients who have these features, I think steroids does become mainstay of treatment, and they do go on for a good long time.
Right. But it's essential to combine it with an immunosuppressant.
Yes, absolutely.
Yeah. A lot of them become intolerant quite soon. So yes.
For a longer period of time, immunosuppressants will really help.
Right. Okay. Thank you, Dr. Reeja.
Thank you, ma'am.
Presentation.